Good evening, everybody, and welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Mustafa Citak from Hamburg, Germany. Dr. Citak is an associate professor and is currently working as senior consultant orthopedic surgeon at the Endo Klinik in Hamburg, Germany. Despite his clinical work schedule, he's employed as the director of research department as well as the fellowship director. Dr. Citak has finished his residency in orthopedic trauma surgery at the University Hospital Bergmannschell-Bochum in Germany. Since 2016 November, he's working as joint replacement surgeon at the Endo Klinik in Hamburg. To this date, Dr. Citak has published over 200 peer-reviewed articles and book chapters in numerous highly ranked journals. He's a reviewer for diverse highly ranked journals such as Journal of Bone Joint Surgery American, as well as an editorial board member of 2 peer-reviewed journals. Due to his profound research experience, he represented a member of the organizational team for the International Consensus Meeting ICM for periprosthetic joint infection held in Philadelphia in 2013 and 2018. In 2012, Dr. Citak was honored for his scientific work with Evidence-Based Medicine Award, followed by the CICOT CCGR Award in 2019, and was selected to represent the CICOT Research Grants Committee Chair in 2020. Dr. Citak is also in the editorial board of 2 renowned journals, which are listed in the medical database PubMed. So today, it's my great honor to introduce you to Dr. Mustafa Citak from Hamburg, Germany. Over to you, Mustafa.
Thank you so much for the invitation and for the great initiative from your side. It's a great honor for me to present the one-stage septic exchange. Here are my disclosures. As you know, periprosthetic joint infection is a devastating complication, and after total knee arthroplasty, if you look at the top 5 causes for failure, PGI is the most common reason for revision surgery. So, according to so many studies and so many projects, we are still fighting with a prosthetic joint infection after total joint replacement. If you have a chronic infection, you have to do exchange arthroplasty. We are always discussing on the meetings the same question. Should we go for 1 or should we go for the 2-stage septic exchange? If you look at the literature, worldwide, the 2-stage septic exchange is still the golden standard. But if you look at the literature, you can see that recent studies suggest that the 1-stage septic exchange may provide superior outcomes, including lower reinfection rates and superior function in selected patients. The Endo concept is a 1-stage septic exchange because it was introduced in the 1970s in our hospital. Until now, we have performed more than 10,000 cases with a success rate in more than 90%. But if you look also in our hospital, not every patient is a good patient for the 1-stage septic exchange. That's the reason why we are performing in 85% of the infected cases with a 1-stage septic exchange. So first of all, we have to think about the general principles. So we are, as I mentioned before, chronic infection. And in our clinic, we say, if you have an infection more than 3 weeks, we say it's a chronic infection. So implant retention can be performed only within the first 3 weeks after infection. So make sure if you have an infection more than 3 weeks, you have to go for the exchange arthroplasty. Radical debridement is the main key point of the success of the 1-stage septic exchange. Radical debridement means removal of all foreign material or infected tissue. As you can see here, if the bone is infected, you have to resect or you have to remove the infected bone as well. And of course, you need antibiotic-loaded bone cement. Antibiotic-loaded bone cement was first introduced from Professor Buchholz. Professor Buchholz is also the founder of Endo Klinik, and with this great idea, the infection rates in the 1960s and 1970s goes down. As you can see here, in 1968, 68 after the total hip replacement. The infection rate after primary was 6.3%, but after introducing with cement, antibiotic load cement, bone cement, the infection rate goes down beyond or below 1%. So here's our endo concept, our treatment algorithm. Of course, you have to do the first diagnostic. You have to identify the germ. And if the infection is more than 3 weeks, as I mentioned before, we can go for the one-stage septic exchange, as you can see here. So in 85%, we can perform the one-stage septic exchange. But if you cannot identify the germ, we go for the two-stage septic exchange. And if the PGI is less than 3 weeks, we try with the DARE procedure, had a success rate of around 50%. So let's start first with the diagnostic. As you can see here, I think everybody knows there is no doubt. There is no sterile sinus. All those cases are infected. But what about this knee? As you can see, this patient had a surgery. The scar is relatively normal, but you cannot say, is this knee infected? So you have to go for the next diagnostic test, because we did a study in our hospital. In 32%, the patient of PGI have normal soft tissues. So think about, if the patient has normal soft tissues, the patient can still have an infection. So our diagnostic protocol is like this. If you have a patient with an artificial joint inside and it's painful, maybe after 1 year, you have to think always for PGI, at least you have to rule out a PGI. If the CRP levels are elevated and you have no other reason for the elevation of CRP, you have to rule out a PGI. And if the patient history is suspicious, for example, persistent wound secretion, fever, wound healing problems, you have to always think about a PGI, and at least you have to rule it out. So how is the procedure? We are always doing a preoperative aspiration if we have a suspicion for PGI, or if we have a patient for a revision arthroplasty scheduled, you have to rule out the PGI. So we are performing, as you can see here, the aspiration in a operation room conditions. The antibiotics has to be withdrawn 14 days prior to the aspiration. And if we take the aspiration, we have to do the cultures for at least 14 days. And no local anesthetics or no saline rinsing. As you can see here, this is a test, what we are not always doing, but this was from a study. This is a alpha-defensine Xenova test. It's a fast test. And you can see here, this is sometimes if you have a surgery, during a surgery, we have a revision case, you can rule out the PGI, because this is, I will show you later, has very good sensitivity and specificity of the results. And you can have the results within 10 minutes. You have also the possibility of the leukocyte esterase test. And in those cases, I recommend to perform the leukocyte esterase test and the Xenova alpha-defensine test, as you can see here. So if you have here the red marks at alpha-defensine, it's positive, but you need both markings, otherwise the test is not valid. Here's the leukocyte esterase test, what I mentioned before. You can have the results within 2 minutes. So in our hospital, we have 6 diagnostic tools. First of all, the serum CRP values. I will show you on the following slides the results of all tests. First of all, if you have the synovial fluid, we need for sure the culture, because we have to treat the germ. That's the reason why we have to go first with the culture and to identify a culture. Second, alpha-defensine quantitative tests, like the ELISA test, not the test what I showed in the short video. Leukocyte esterase test we are always performing. And then cell count and the granulocyte percentage, those are the tests what we are usually doing in every case who has a suspicious for PGI or a patient who has been scheduled for a revision arthroplasty case. There are many definitions of PGI. We are using the ICM criteria, the new ones from 2018. You can divide it in major criteria and minor criteria. The major criteria of one of those, the patient is infected. For example, if you have two positive growth of the same organism using the standard culture methods, or if you have, as I showed before in the images, if you have a sinus tract, you have a definitive infection. What about the minor criteria? You can choose the serum CRP and you can have the scores. For example, in chronic, if the serum CRP is more than 10, you will have 2 points. We are not performing the D-dimer, as you could see in my previous slide, but some hospitals are doing it. Serum CRP or D-dimer, if you have an elevated value, you will have 2 points. Elevated erythrocyte sedimentation rate is 1 point. Again, we are not performing this in our hospital. We are only doing the serum CRP and those values, as you can see here, the synovial cell count, leukocyte, or the positive alpha defensine, as you can see here, the cutoffs. And later on, you have to count those points. And if you have more than 6 points, or the 6 points, or more than 6 points, you have an infectious tissue. This is our algorithm, what we are doing in our hospital at Endo Klinik to define a PGI. We have done a study, so we look for the validation criteria of the 2018 International Consensus Meeting minor criteria. We included 345 PGI cases, and we found that the diagnostic performance was relatively high, with a sensitivity of 96% and 95% for hips and knees. So this is a diagnostic protocol. So we are always doing, as I said before, a joint aspiration. Sometimes you have suspicious for PGI, so you cannot identify any germ. In these cases, we are doing a control aspiration, so we are doing all the 6 parameters again. And if we have still a suspicious for PGI, we are going for the open biopsy. So in those cases, you have to take from different parts, from the knee or from the hip joints or from the possible infected joints, biopsies, at least 5 to 6. And then in 50 cases, you can have additional information with the germ. And if you have this additional information, you can go for the one-stage septic exchange. If not, you have a culture negative infection. If you have still the high suspicious of you, or if you have PGI according to the minor criteria, we are going in those cases with a 2-stage septic exchange. Here's our overview of our diagnostic study results. Serum CRP has a sensitivity of 86. Sensitivity of leukocyte esterase, as I showed, it's the fastest 2 minutes you can have the results. With the high sensitivity was 100%, and the lower specificity is still high, of course, 96.5%. The ELISA test is for both 97, and the Xenovasure, as you could see also in the short video, has a sensitivity of 97 around, but the specificity was very high with 100%. So what about the treatment? So as I said, we are performing in 85% the one-stage septic exchange. So not every patient is fulfills the requirements. First of all, we need a chronic infection. One more time, if you have a chronic infection, if the infection is more than 3 weeks after primary implantation, or if the from the beginning of the symptoms, we are also more than 3 weeks. We are also defining it for the chronic infection. So this is has to be you need a chronic infection. Second, you need to know the germ. So if you cannot identify the germ, as I showed before, we cannot go for with a one-stage septic exchange. And you need, of course, local antibiotic therapy. Sometimes you have allergies to antibiotics. This is very, very rare, but it can happen. Then it's not a good idea to go with the one stage. And if the radical debridement is not possible, so this has to be possible, because this is a key factor of the success of the one-stage septic exchange. And if you have a primary wound closure possible. So for example, if you have a small fistula, you can close a wound within the same surgery. There's not a contraindication, but if you look at the ICM recommendations or other surgeons, they say what fistula is a contraindication. In our hospital, this is not a contraindication. I will show you later on our results why it's not a contraindication. So again, if you fulfill all these criteria, like if you know the pathogen, if you have no allergies, if you can perform a radical debridement, and if you can perform a primary wound closure, you can go for one-stage exchange. Otherwise, you have to go for the two-stage septic revision arthroplasty. Here's our clinical pathway in one stage. So you can divide it for preoperative, intraoperative, and the postoperative procedure. So we are usually seeing the chronic infected patients in our outpatient clinics, and they were scheduled for the surgery. Usually they came first day of admission, but the surgery is not on the next day, because this is a multidisciplinary team. So we have to talk to the microbiologists with all the other colleagues to prepare it carefully, because this is an important procedure. So after performing all those steps, we are doing usually the surgery on the third day, like with a one-stage septic exchange. I will show you later a short video. So usually it takes 2 to 4 hours, the surgery. And second day, they can use a full weight bearing mobilization in, I would say, in almost every case. We cannot say in every case, because there are sometimes cases they are not allowed to do full weight bearing. This is a postoperative course. I will mention it later. 12-day antibiotic therapy, suture removal, and then the patient were discharged 15 days, usually after surgery. In our study, we had average length of stay of 14 days. So here are some key steps of the one-stage septic exchange. The main thing is removal of all foreign bodies. This belongs also to the two-stage septic exchange. There are studies. If you leave foreign materials or infected tissue inside, you will have a high risk for reinfection also in the two-stage septic exchange. And this is, as you could see here in the short video, it's not always easy to remove all fully integrated components, but you have to do it, and you have to remove all the complete cement mantle if the prosthesis was cemented. Usually we have different approaches. We are going with the endofemoral approach. In 99% this is possible, but you need the specific instrument, you need the specific chisels and all the specific instruments. Otherwise you cannot perform this endofemoral approach. Sometimes the people go for the extended trochanteric osteotomy or cortical fenestration. Usually, as I said before, in 99%, we can find a solution with this endofemoral technique approach in our surgeries. But what is radical debridement? Radical debridement is removal of all infectious tissue, and this is a challenge. Where is the interface to the healthy tissue? And this needs a learning curve. And the learning curve is a little bit slower than performing a primary total hip replacement. This is a major part of the radical debridement, to find the interface to the healthy tissue. And radical debridement, as you can see here, means with the capsule, the complete excision, not only curettage, bone. As I showed before, if you have infected or osteomyelitic parts or sequester, you have to remove the bone. Otherwise, you will have a high risk for reinfection. And if you have soft tissues, fistula, abscess, or other infected muscles, you have to remove all those infected tissues. And also you have to remove all foreign material. This is the most important part of the radical debridement. I will show you in a short video a case of infected total hip replacement, how to perform the one-stage septic exchange. First of all, as you could see, the debridement starts with the excision of the old scar. Here you can see first there was some abscess, so you have to take it out. And this video is a little bit not the normal tempo. Otherwise, we would stay here 2-4 hours. And you have to remove, you can see here the femoral head. Then you have to debride everything. And as I said before, you have to remove all infected tissue. Here, first of all, here you have to remove the femoral component. This is important to avoid any fracture. You have to loosen the bone component interface with these chisels before you take it out. And we have a specific explant system. It calls NIDA, and you can fix it on the cone and you can remove it with a specific extractor. Then you have to take some biopsies from the femoral canal for microbiological and histological examination, and then you have to debride the whole canal. And if you have infected tissue or foreign material, you have to take it out. And then if you finish this, you have to go to the acetabular component. Here you can see here, first of all, then you have to, here's the explant system from Zimmer. This is important to avoid any severe bone loss. And if you remove the cap, as you can see here, you have to take again from those parts as well the biopsy. And after removal of all infected tissue, here there's 2 seclage. As I said before, you have to remove all infected tissue. And if the bone is infected, you have to remove the bone as well. So here's further radical debridement. And after finishing the radical debridement, so the next step is the clean period. So you have to redrape and you have to change all the materials. And afterwards, we are starting with the reimplantation. As you can see here, here is a, yeah. And then we start with the antibiotic-loaded bone cement. This is a recommendation from our microbiologist. That's the reason what I said before. We need to admit the patient 2 days before surgery to make all the plans, because this is very important. And after this surgery, the patient is allowed to use full weight bearing. And as I said before, this is our former microbiologist. He's retired already, this is Dr. Frommel. And important thing is that you need high dose local antibiotic therapy for a short-term systemic antibiotic therapy. This I showed before, but if you focus on the postoperative course, 12 days of postoperative antibiotic therapy, IV, and then the patient will discharge home or they go later on to the rehabilitation clinic. What about the literature review? If you look at the literature review, as I said before, in the 1970s, the one-stage exchange began in Endo Klinik. Here, let's start first with the total hip arthroplasty one-stage septic exchange. Here are some clinical results. And if you look at the clinical results, there are a limited number of long-term results, but infection-free survival is between 83 and 100% according to the current literature. What about our results? If you look at our results, 10-year results, which has been published 2 years ago in Journal of Arthroplasty, we had an infection-free survival rate of 94%, but the revision-free survival was higher. And if you look here, the reasons for failure, the most common reason was dislocation with 9 cases. You can imagine if you perform a radical debridement, if you have to remove, for example, the proximal femur, you have a higher risk for dislocation in those cases. That's the reason why we recommend in those cases dual mobility cup to avoid or to reduce the risk of dislocation. Infection in those cases was 5%. As I said before, the infection-free survival rate is 94%. If you look at the one-stage septic total knee arthroplasty literature, there are similar results between 90.9 to 98% eradication rate. And here's our study, which has been published in Core Clinical Orthopaedics and Related Research in 2016. Again, the 10-year results, and with an infection-free survival rate of 93, but the surgery-free survival rate was better. in those cases with 91% using a rotating hinge design. Here's an important two papers. Why do one-stage exchanges fail? Here's a paper which is published in JBJS American 2019, looking at the risk factors for the knees. And this is another paper for the hips, which is also published in a highly ranked journal, Klinik Orthopaedic related research. Here, let's start first with the results after the one-stage knee exchange. You can see that the mean time to failure is around 2 years, 25.2 months. But if you look here, you can see that the majority of cases failed within 7 to 24 months. What were the reasons? If you look at the top 3 causes for failure, the most common reason in the knees was the recurrence of infection with around 52%, followed by aseptic loosening with around 41%. And we looked in this study for the risk factors. This is for the re-revision for any reason, not only reinfection. And if you look here, the top 3 causes, the isolation of Enterococcus, if you have an infection with Enterococcus, you have a really high risk for a re-revision with around 19-fold higher risk. And if you have a failed one stage, you have also very high risk with 15.4. If you have more than 4 surgeries, you have a higher risk with 4-fold higher risk. And of course, those are really complex cases. If you look only on reinfection, the results are very similar, but on number 3 is the persistent wound drainage. We know if you have a persistent wound drainage, you have a higher risk for infection. This is also in cases with, in primary cases or in aseptic revision cases. This is, was also found in the one-stage septic exchange. Interestingly, if you have a streptococcus infection, you have a high risk with 3.4 fold higher risk. Enterococcus and streptococcus are really difficult to treat. So let's focus on the hips. This is a similar study which was performed on the hips for the risk factors. And here, not reinfection was the most common reason, dislocation with around 43.8% dislocation, as I said before. If you have a proximal femur resection and if you have a higher risk for dislocation. And the second common risk for failure was reinfection with around 33%. So that's the reason what I said before. In those cases, if you perform a one-stage septic hip revision arthroplasty, we recommend to use a dual mobility cup because to reduce the risk of dislocation. What about the length of antibiotic treatment? This is usually a hot topic. We have done a systematic review on the optimal duration of intravenous antibiotics following the one-stage septic tool hip arthroplasty. I was one of the co-authors. So we look for the 166 studies were assessed for eligibility. So we at least 21 studies were selected, and with a number of 643 patients undergoing the single or the one-stage septic revision total arthroplasty for the PGI. Here are the results. There were 2 groups, antibiotic less than 4 weeks and antibiotic lengths like range for between 4 to 6 weeks. And interestingly, the eradication rate in those cases with less than 4 weeks was even higher with 92.6% compared to the longer antibiotic treatment with 4 to 6 weeks with eradication rate of 89.3%. The limitation of this study is that we don't know if those cases are maybe more difficult to treat. That's the reason, I mean, those cases with the longer antibiotic treatment, this could be the reason why the eradication rate is lower than those cases. But to be honest, we need large-scale multi-center randomized controlled trials to determine the optimum duration of antibiotics following the one-stage septic exchange. In our hospital, the IV treatment is usually 14 days. So this is what I like really much, why we are performing the one-stage septic exchange. There are more than 5 reasons, I know, but I will show you the 5 reasons. The most important reason is, this is not listed here, but the most important reason is you have only one surgery. But let's start with number 5. What about the blood loss and the need for blood transfusion? This is a study what we have performed with Rodman Institute, with J. Parvizi. And if you count the 2 procedures, and you have to count it because if you have a 2-stage septic revision, it's a planned 2 procedures. So you have a higher risk or higher rates of blood loss and transfusion rates if you compare with the 1-stage septic exchange. Lower in-hospital complications. This is a study also from our group. This has been published last year. And you have, if you look here, the 1-stage and the 2-stage septic exchange, you have a lower risk for complications such as acute renal failure performing the 1-stage septic exchange. What about the lower in-hospital mortality? This is also from our study. The lower in-hospital mortality is lower performing the 1-stage. This is also found in a study from the Norwegian arthroplasty registry data, and you can see that 1-year mortality rate in 2-stage is 1.6 compared to 0% of the 1-stage septic procedure. Number 3, if you look for the 1-stage, it's more cost effective, and it means the 1-stage was more cost effective in both decision trees by producing less cost per quality gained. And higher quality of life. As I said before, you have only 1 surgery in those cases, and if you have 1 surgery, you have also a higher quality of life performing the 1-stage septic exchange compared to the 2-stage septic exchange. And this study came from the United States. So here are some more recent studies from the 1-stage septic exchange. This is a study what we have performed in younger patients, the 10 to 24 years results in patients younger than 50 years of age in total hip arthroplasty. And we had a really high eradication rate of around 96%. So overall survival rate was around 77%. Again, if you perform the revision total hip, it's higher. It's the most common failure is not reinfection, is usually dislocation. What about the methicillin-resistant Staph aureus? So we have performed the 1-stage in a prior study from our group, and they identified, this is a study from 2000, also from Endo Klinik. They used 20 cases with the 1-stage in 15 with hips and 5 with the knees, with a follow-up of 16 months, and the eradication rate was only 61%. But if you look here, they said MRSA is a problematic infection, and the intraoperative view of an antiseptic and systemic administration of rifampicin, as recommended by CIMALI, is a further possibility. So what we did now is a recent study. This is published, I'm not sure, I think last year, 2020, I think, or 2019, I'm not sure, sorry for that. But if you have an improved treatment strategy like rifampicin added, we had an eradication rate of 93%. So if you have an MRSA PGI and if you use the current techniques, you could have better results to excellent results in the management of MRSI periprosthetic joint infections. As I said in the beginning, there's always this discussing, should we go for 1 or should we go for the 2-stage septic exchange? Here is a study, a meta-analysis comparing the 1 and 2-stage surgical revision. And if you look here, they use 44 studies with around 1,900 patients. And if you look here, the risk for reinfection was even higher in the 2-stage septic exchange, which was also significantly higher. Here's another study of the knees, single stage versus 2-stage, and the eradication rate was very similar, quite better, a little bit better than in the 1-stage compared to this 2-stage. Again, if you look at the eradication rate between the 1 and 2-stage septic exchange, you have no really differences. but as I showed before, you have many advantages performing the one-stage septic exchange. Here's another study I showed before with the mortality rate, and again, mortality rate is higher, but the results here a little bit higher with 13.9 compared to 11.5. But again, this is relatively similar if you look also in the Norwegian arthroplasty registry. Here's a study from United States again, single versus two-stage. There's a rising popularity of the single-stage exchange also in North America. And as I showed already, comparable success rates regarding the eradication rate and better functional benefits to the patients. And as I showed already in my advantages, you have a decreased burden to the healthcare system. This is an important trial. This was started 2016. There's a prospective study, a randomized controlled trial. We call it also the INFORM trial. But unfortunately, until now, we do not have any results. But this study is very important to see which procedure is better regarding the eradication rate and the functional outcomes if you compare the one versus the two-stage septic exchange. It was my great pleasure to present the one-stage septic exchange, the surgical technique, the indications, and at latest, the literature review. Thank you so much for listening.
Thank you, Mustafa. Fantastic lecture. And it's really enlightening for anyone who is into arthroplasty. Just a few questions. Mustafa, I've hosted a lot of surgeons all over the world who do joints, and we have discussed about infected joints, and most of them are stuck with a two-stage revision. And one of the reasons that they all said was they do not have an excellent microbiological background. So you have mentioned about alpha defensin, leukocyte esterase, and even extended culture, or even sonication of implants. So what do you think is that difference? Is it technology in microbiology that makes the difference?
That's a very good question. I think the microbiological part is very important. As I showed you, we do not have in all cases a germ. We have also the same problem sometimes. For sure, you look at the patient, it's for sure infected. We are doing our aspirations, including the alpha defensin and the leukocyte esterase test. Sometimes we still think, or we know it's an infection, but we cannot identify any germ. That's the reason why we are performing a control aspiration, and as I showed in my diagram. And if it's still, you have a high suspicious for PGI, we are doing an open biopsy. And this is a possible method to get additional information about the possible germ. And in our study, which is not published, but which is almost published in AOTS, we can find 50% additional information. Like, for example, of all patients who performed the open biopsy, 50% we could identify a germ to perform the one-stage septic exchange. But I agree absolutely with you. The microbiological part is very important. And I think the technique of the aspiration is also important. Sometimes they do not have really joint fluid. I mean, I could see this in some hospitals. They are just doing aspiration, but that's the reason they are putting the saline rinsing, and they said, okay, we are done. Of course, you cannot find a germ. If you have the best microbiologist, you cannot identify a germ if you have no real joint fluid. But to be honest, I agree absolutely. The microbiologist is a very important part, and to identify the germ, because if you cannot identify the germ, you cannot go for the one-stage septic exchange.
And what about sonication of implants? There is a lot of discussion about sonication to get the organism.
Yeah, we are not performing the sonication routinely, but you mentioned before, we are sometimes doing the PCR test. If the patient has, sometimes for acute infection, for example, if the patient has already received antibiotic treatment in another hospital, in those cases, we are performing the multiplex PCR to identify the germ. but we are not doing it routinely in chronic PGI cases. Sonication, we are doing sometimes. We are doing it if you have a two-stage septic exchange. If you remove the implants, we are sending it to the sonication. But this is if we go for the two-stage septic exchange. Otherwise, we are not doing the sonication. But we are still doing, if, for example, if we have a culture-negative infection, and we go for the two-stage septic exchange.
And do you by means do any intraoperative frozen section for your surgeries?
No.
Okay. And what are the antibiotics that are commonly used? Like you mentioned about vancomycin. And what are the other heat-stable antibiotics that you use?
Usually the antibiotic treatment recommendations come from the microbiologist. And this is, we cannot say we are performing routinely because every patient is different. That's the reason why you need a multidisciplinary team. And I know it from Dr. Frommel. Every patient has some different factors, for example, different illnesses, different history of the PGI. So we cannot say you can use this in this PGI case like this treatment, and in this PGI case this treatment. So I think you need a microbiologist, you need a multidisciplinary team, and you have to choose medication individually according to the patient's history and like comorbidities.
Thank you, Mustafa, for that. Senthil is also in our Zoom room. Senthil is a staff orthopedic surgeon based in Dallas, Texas. Senthil, your questions to Dr. Citak.
Dr. Citak, excellent presentation, and it's a very complex topic. My question is, like you said, all components needs to be removed, but sometimes we encounter this fully porous coated uncemented stem, and you say you use mostly 99% endofemoral approach. Can you give us some tips on how to remove those fully porous coated stems through endofemoral approach?
Yeah. As I said during my presentation, the most important thing you need the specific instruments. If you do not have the specific instrument with a different type of chisels, you cannot remove the cemented or the cementless implants. If you go for this endofemoral technique, you need the specific instrument, and if you have the specific instrument, you have to lose the fixation from the cement or from the bone and the component. Otherwise, you cannot remove it, or you need specific explant system, as I showed, to remove the prosthesis. But you are right. Without the instrument, it's really hard. Maybe then you have to perform in hips, for example, the extended trochanteric osteotomy.
Mm-hmm. And you kind of the approach-wise, if somebody had, what's your preferred approach? Posterior approach or hard hinge approach?
On the hips?
Yes, on the hips.
Posterior.
So if somebody had a surgery through a hard hinge approach, and if they get infected, would you still go through a posterior approach, or will you use the previous incision?
We always a posterior approach.
Okay. All right. Other than that, I don't have any other specific questions because your story, I think, was extensively covered with very good data supporting it. Thank you.
Thank you, Dr. Citak. I think that's all the questions that we have for this session. Fantastic lecture. And I'm sure this lecture is going to reach a lot of people all over the world. Thank you so much for joining in.
Okay, you are welcome. Thank you also for the invitation, and enjoy your day. I don't know, what time is right now?
We are 9:30 p.m.
Okay, then have a good night.
Yeah, bye-bye. Good night. Thank you, Senthil.
You're welcome.
Bye-bye.